So abnormal rhythm comprises of the three rhythms. Here you can see that arising from the depolarization arising from the atrial muscle, or if it cannot arise from the atrial muscle, it will arise from the AV node or the AV node, which is also known as nodal or the junctional rhythm, or if that arises from the ventricular muscle, which is known as the ventricular rhythm. So abnormal cardiac rhythm can begin in one of the three places, like the atrial muscle, the region around the atrioventricular node, which is called nodal or properly the junctional or the ventricular muscle. And although electrical activation might begin at specific points within the atrial and ventricular muscle, abnormal rhythm can begin anywhere within the atria or the ventricles. Sinus rhythm. Okay, so if this is the heart, then electrical activation might begin at specific points at ventricular, atrial, or the ventricle. But we must be sure that abnormal rhythm can begin anywhere within the atrial or ventricle. It might begin over here, it can move from anywhere. The depolarization can begin from anywhere from the atrium or the ventricle. From here, here. It can begin from anywhere. Sinus rhythm, atrial rhythm, junction rhythm together constitute the supraventricular rhythm. And we must be sure that this is the heart. And SA nodal, sinus rhythm, AV nodal, atrial, anywhere from there. This is known as the supraventricular rhythm. And that arising from the ventricle is known as ventricular rhythm. Okay. In supraventricular rhythm, depolarization wave splits the ventricle in the normal wave via his bundle of his and his so if it arises from the nodal sinus node in sinus rhythm, SA node, AV node, then the normal depolarization. If it arises from the AV node, a bundle of his, then it will go and depolarization here. If from the atrial rhythm it goes to the AV node, then from the bundle of his it goes. So the QRS, T, everything will be normal. Only there will be the alteration in the P wave. So it will have the normal QRX complex. Okay, narrow QRX complex. But in ventricular rhythm, the depolarization wave spreads through ventricle. No any wave of depolarization is coming from from the supraventricular region. So the depolarization wave spreads through the ventricle by an abnormal and slower pathway from any of the ventricular. So the QRX complex will be larger. Okay, because it is slow, it takes the time and 0.4 millisecond, 40 millisecond by small square box, it will take more large. So there will be the wide QRX complex, and that will be abnormally shaped, and so will be the repolarization. So the abnormal PQRS and T wave will be formed in case of the ventricular rhythm. This is the thing that we must know, that in the supraventricular there will be the normal QRX, only the P wave will be abnormal, while in the ventricular rhythm the QRX will be abnormal, will be wide. So you can see over here the same thing is written here. The same thing has been written over here. Atrial muscle, here you can see abnormal rhythm, atrial muscle, AV node, junctional, ventricular muscle. Sinus rhythm, atrial rhythm or junctional rhythm with the supraventricular rhythm. Depolarization splits by bundle of his, normal QRX complex. This is the narrow, but this has exception if that is coming from the supraventricular region. Okay, that might not show the normal QRX complex. So what is the exception? Supraventricular rhythm with the right or left bundle branch block. Okay, it will have R, S, R pattern and the M pattern. So that will be the different part. Okay, even though that is arising from the wave of depolarization is arising from the supraventricular region, and also the Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. Okay. And the ventricular rhythm, you can see the depolarization spreads by the ventricle, then the abnormal slower pathway by the Purkinje fires. That's so Purkinje fires, so the wide abnormal QRX, and so on with the repolarization showing abnormal T wave. So these are the things, and you can know that bradycardia is the slow sustained rhythm, tachycardia is the fast sustained rhythm, extrasystole occurs as early single beats, and the fibrillation is the activation of the atria or ventricle, which is disorganized. This is sustained, this is sustained, this is disorganized activation of the atria and the ventricle. So these are the terms before we start. So let's start with every topic: bradycardia, tachycardia, extrasystole, and fibrillation. So let's move to the bradycardia. So in the bradycardia, intrinsic frequency of SA node depolarization is like 70 beats per minute, while the intrinsic frequency developed by the AV node for depolarization is 50 beats per minute. Intrinsic frequency of atrial zone for is 50 beats per minute, and the intrinsic frequency of ventricular muscle for depolarization is 30 beats per minute. So this is the fail-safe mechanism. Okay, if the SA node, so this is the heart, this is SA node, this is atrial, this is nodal, and this is the ventricular. This will produce the depolarization and will cause the heart rate at 70 beats per minute. This will cause 50 beats per minute, intrinsic frequency. And this is the ventricle will have intrinsic frequency for 30 beats per minute. This is the fail-safe mechanism. If this cannot work, then this will be working, either this or this. And if this cannot work, then either this will be working. So this is the primary side. These all are the secondary side. But the secondary side, which have the lower frequency of depolarization from the SN node, so there will be the no competition. Okay, it will be producing more frequency of depolarization. So this will be the one which will be producing the wave of depolarization. Okay, so this is like if 70 cannot do, then 50 will do. If 50 cannot do, then only the 30 will be doing. So there will be no competition because of this. If this was also producing the beat, this was also producing beat, then there might have been the competition, there might have been different alteration. This is producing wave of depolarization on its own, this is producing depolarization on its own. There will be not any systemic contraction of the atrium or the ventricle. So this is the fail-safe mechanism, and the secondary side will have lower frequency of depolarization from the SN node. So this will only be working, and if this is not working, then the 50 will be working. And if the 50 is not working, then only the 30 beats per minute having the frequency of intrinsic frequency, this will be working. So the higher the intrinsic frequency, that will be working during the production of the rhythm. And why they are known as escape rhythm? This is known as escape rhythm because when this doesn't work out, then as I mentioned, the 70 beats per minute this produces, this has inhibitory action on the atrial, this has inhibitory action on here, this has inhibitory action over here. And while this is working, this is having inhibitory action over ventricular muscle. So the every superior or senior thing will have the inhibitory action. So this, when the primary side is not working, then the second side having low high frequency will be depolarizing, and that is known as escape. So this is escaping the rhythm, so this is known as the escape rhythm, as you can see here, because the escape, the inhibition by more active SA node. Okay, this is more active now because this produces 70 beats per minute, and for this is more active. So this is when they escape the inhibitory action by the more active node, then that will be known as escape rhythm. This is not a decider but average to save a life. So this is more than understanding it as a understanding it more as the escape disorder, we can know that this is for the saving of the life. Okay, so what is the atrial escape here? You can see if the rate of depolarization of the SN node slows down, then the different focus in the atrium takes over the control. It can be anywhere. Okay, it can be anywhere from here, any from the atrial muscles is capable of depolarizing. So any of that. While here we see here we'll take this one, we'll be taking this one. Okay, this is not depolarized, then the wave of depolarization will go over here, then here, then that will be going over here and here. So you can see here is the sinus bit, PQRST, but this is trying. No any depolarization from the atrial muscle. The first wave of depolarization came over here, it went down, but there had been no further depolarization. So there has been the escape rhythm from the atrial. So you can see here is abnormal P wave, but the rest QRST is normal. And again there will be the sinus rhythm, PQRST coming from the sinus rhythm, PQRST. But you can see here the delay, then the abnormal P. Delay abnormal P means there has normal QRX. This is supraventricular rhythm because the QRST is normal, but the P is abnormal. So the depolarization is here is wrong. Here is being something wrong, and here is the delay. So there might be the atrial escape. So this is the ECG for the atrial escape. Now we can see for the nodal or the junctional escape. If the region around AV node takes over focus of depolarization, rhythm is called nodal or junctional escape. Okay, if the region around the AV node takes over focus of depolarization, rhythm is called nodal or the junctional. Here you can see the P, PQRST, but here is no P. You can see QRST, here is no P, QRST, here is no P. You can see here QRST. So no any atrial depolarization, means there from the AV node the QRST is being formed. As you know that from the AV nodal delay, AV node will not be having any P wave. This shows the AV nodal delay, and the depolarization from the AV node will produce QRST. So as there is no any P, we do not see any P, but there has been the depolarization of ventricular depolarization, we can understand that this is nodal or the junctional escape. Okay, ventricular escape. What is ventricular escape then? When the conduction between atria and ventricle is interrupted by complete heart block. Okay, there has been complete heart block, ventricular block. It's seen. However, it can occur without complete block, but however, ventricular escape can even occur without complete block, and it can be single. So this is the ventricular. This will give the wave of depolarization. You can see here the abnormal QRS. Okay, abnormal QRS. This is something ventricular depolarization. Here you can see the P wave, but no depolarization. Then again no depolarization. Atrial depolarization following by no ventricular because of the complete heart block. And there you can see QRST. This is depolarization is being from the ventricular region. Okay, so this is abnormal, and P is not in corresponding with the QRX complex. So you can say that this is the ventricular escape because there has been QRS, there has been the ventricular depolarization, but not in any relation with the atrial depolarization. So this is the ventricular escape in the ECG. Okay, here you can see PQ, QRST, PQRST, PQRST. Okay, but here is no P. Then there is QRST. Then PQRST, 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 PQRST. But here has been no multiple number of PPPPP, one QRS. But here QRST, it is occurring as a single. Okay, it is occurring. This is the ventricular escape can occur as single. So this is, and this it can occur without complete heart block, and this can be, here is the complete heart block, and this is the ventricular escape. And when there is no heart block, there is ventricular escape. So what the ECG looks alike. If there is no heart block over here, here is no heart block, right? But still there is ventricular depolarization, and it can occur as single, and no any complete heart block is requirement or mandatory like here. So this is just trying to say that ventricular escape can occur even without the heart block, and it can occur as a single beat. And let's see another one, the accelerated idioventricular rhythm. This may look like ventricular tachycardia, but always remember that the ventricular tachycardia, you must calculate the rhythm, then that must be 1, 2, 3. 300 divided by 3 means 100 beats per minute, right? So this is not the ventricular tachycardia. To occur as the ventricular tachycardia, you must have 120, more than 120 beats per minute. It is often associated with MI, and it is looks like ventricular tachycardia, but it is benign and does not require the treatment. Here you can see okay, here you can see after 3 sinus beats, the SA node fails to depolarize. 1, 2, 3, it is not able to depolarize and escape focus from the ventricular. There is no P, so the QRST. So this is the escape ventricular rhythm arising and forming abnormal QRS, abnormal T wave, abnormal QRS, abnormal T wave. So this is also the ventricular escape, but this is known as accelerated idioventricular ventricular rhythm. So this is the thing for the abnormal rhythm.